Just want to move into a slightly different angle. In your book, Better, you discuss the new informality of medicine, in which, among other things, we've dispensed with the white coats and many doctors allow patients to call them by their first name. As you put it, the boundaries that once guided us are now blurred. In Australia, and I'm sure in America as well, many of our disciplinary complaints relate to boundary violations. How do we return to sort of clearer boundaries with our patients to protect them and us, without going back to being the sort of 50-style doctor, authoritarian, know-all doctor?
Well, I did make a slightly old-fashioned case for saying you use people's last name until they tell you otherwise. You're Mr. or Ms. So-and-so, and that you don't necessarily invite them to call you by your first name, unless you eventually develop a very clear and relationship. You're a GP and you'll know people for, many, many years of their life, and then that can change. But even then, finding some ways to be able to make it clear you're there in a specific role. I think that the conception of the doctor, though, as the kind of, father knows best kind of figure, the paternalistic doctor who doesn't necessarily tell you everything that's going on with you, tells you exactly this is what you're going to do, and, have no discussion whatsoever. I think we are moving past that, and deservedly so. But we've been caught in this place where it's almost a retail doctor. The idea that the doctor gives you, I describe it in my most recent book saying, it's, you have the red pill and the blue pill, and it's like going to a shoe salesman. Do you want the red shoes or the blue shoes? Here are the pros and cons of the one pair and pros and cons of the other. Now, which one do you want? And it invites a sense that, I don't really know more than you do about this. I can provide some information. And I think people feel very abandoned in that. They want the benefits of your knowledge. They want advice about what to do. And I argue for the idea that we really need to be the counselor figure who is able to elicit what people's goals, what their priorities are. Only they can tell you what matters most in their life, what they're willing to sacrifice, what they're not willing to sacrifice in the course of your care. But then only you can say, here's my experience with the different treatments and what I think might match them. And out of that requires a certain kind of trust and formality and understanding about what each other's role is. And I think that the boundary violations come from the many places where a medical encounter is a very intimate kind of thing. People are telling you their secrets. They're telling you if they've, had affairs and are worried about having a sexually transmitted disease. They're telling you about, you're trying to elicit whether they have drinking problems or drug abuse problems, or whether they have stresses in their life of various kinds. And that trust can be so intimate that people imagine it to be a different kind of relationship than it is. I even go so far as in that particular book talking about trying to figure out how do you deal with the boundaries around a naked person, in front of you, and how do you have that kind of propriety, and argue for using a third party to be a kind of chaperone along the way. And I think those kinds of steps are still important.